Hi, this is Dr. Bhargava, and this short video is about pitfalls and artifacts on FDG PET-CT imaging. Here are a couple of articles that I've published in the past on the related topic. We begin with reviewing the protocol for FDG PET-CT imaging. F18, a positron emitter, has a half-life of 110 minutes. We inject about 10 to 15 millicuries into the patient. We wait for about 60 minutes. And then we do a whole body acquisition from the top of the skull to mid-thighs. Here is the rotating image showing normal distribution of the tracer with most intense uptake in the brain, followed by excretion from the kidneys into the urinary bladder. Uptake in the liver is normally more intense than the spleen. There is variable uptake in the myocardium and in the bowel loops. There is uptake in the extraocular muscles. This is usually symmetric, and there is some vocal cord uptake because the patients are on their phone talking to their relatives during this 60-minute uptake period. Tumors show focal hypermetabolism, and there can be false positives from inflammation and infection. False negative findings are when there is no FDG uptake, but there is cancer present, and this is seen when the lesions are less than 1 centimeter in size and in the situations where the patients have low-grade tumors which do not take up as FDG. Here's our first patient. We are evaluating a lung nodule, and on their rotating image, we find that there is faint uptake in a left upper lobe lung nodule. This lung nodule is about 1.5 centimeters in size. The FDG max measured 1.8, and so it does not meet the PET criteria for malignancy. Visually, it's not more intense than the mediastinal blood pool, and on a dedicated CT of the chest, it shows this central pattern of calcification, which is suggestive of a benign lung nodule. Here's our next patient. On their rotating image, we find that there is a lung nodule that shows focal hypermetabolism, which is seen right here and here, which was biopsied and shown to be lung cancer. Incidentally, we saw uptake in the left side of the neck. This was a soft tissue density in their left parotid, and these are common findings on FDG PET-CT studies. Most of the times when we have biopsied them, they turn out to be a benign tumor of the prostate, such as a Warden's tumor. And that's what happened in this patient. They had a benign parotid tumor. Here's our next patient. The rotating image shows the lung cancer in the left upper lobe. And then in the mediastinum, there is this large focus of intense uptake, which corresponds to fat in the interatrial septum, and so this finding is called lipomatous hypertrophy of the interatrial septum. There is brown fat there that can be FDG avid. Next patient with advanced lung cancer is seen here. On the rotating image, there is this large mass in the right lung. We also have metastatic lymphadenopathy in the right hilum. There are a couple of foci of non-neoplastic uptake. There was some infiltration at the site of injection in the left upper extremity. There is uptake in the vein, and then some uptake in the nodes in the axilla. This is not neoplastic or related to their lung cancer. Also, as the urine is coming down the ureters to go into the bladder, frequently there is some stasis seen in the ureter, and that can be FDG avid as seen here. And so these are two foci of benign uptake in this patient with lung cancer. Here's our next patient. On the rotating image, we see that in their mediastinum on the right side, there is a ill-defined focus of mild uptake, and this focus corresponds to the site of the catheter seen right here. And we see the catheter on the CT image right there. And so this catheter-related uptake is also seen frequently, and it is related to either thrombus or infection at the tip of the catheter. This is our next patient, another patient with metastatic lung cancer, and here is their primary tumor and metastatic disease in the right hilum. They also have brain mets, which I am showing it to you here on the T1 fat saturated contrast enhanced image showing enhancing metastatic disease. On the CT part of the PET CT, it is slightly hyperdense. And look at the PET or the fused image, it is not hypermetabolic. So frequently metastatic lung cancer to the brain are not seen as hypermetabolic foci, and this is probably because there is intense surrounding uptake of FDG, which is physiologic in the brain, and that's why even if the focus takes up some FDG in the background of intense brain activity, it will not be seen as focal hypermetabolism. Here's our next patient. On the rotating image, we see that in both sides of the neck and in the supraclavicular regions and posterior intercostal regions, there are multiple foci of intense FDG uptake, and these correspond to fat attenuation seen on the CT images. So this is characteristic brown fat uptake or brown adipose tissue uptake on FDG PET CT. This next patient also has advanced lung cancer. On this rotating image, we see the primary, we see the metastatic disease on the right side. This supraclavicular hypermetabolic node, also called Virchow's node, would make this patient a stage 4 for their lung cancer. And we also see this extensive skeletal muscle uptake, and a review of their history found that they were using a wheelchair, and that may have contributed to this skeletal muscle uptake that we see on FDG PET. We see not very intense uptake in the brain, and here's the rotating image. And further evaluation of the brain images shows that they have a pattern suggestive of Alzheimer's disease, where there is hypometabolism in bilateral parietal and temporal lobes, also hypometabolism in bilateral frontal lobes, with preserved sensory motor cortex activity on both sides. And that finding is best seen here on this rotating image, but in a lateral projection, the extension of hypometabolism from the parietal to the temporal lobes. This whole strip is hypometabolic on both sides, and that's characteristic of Alzheimer's disease. And so frequently we pick up such things on PET CT studies when we are staging patients for cancer. Here's our next patient, a young woman being evaluated for cancer, and we found that in the pelvis there is a focus of increased uptake. This focus, seen right here, corresponds to the endometrium in the uterus, and this is in a young patient, physiologic. In an older patient, which we see right here, this patient was being evaluated for cancer. They're postmenopausal. We see an uptake in the pelvis. This corresponds to the uterus, and this patient was diagnosed with an incidental endometrial cancer. So remember to look at the patient's age when there is focal endometrial uptake on FDG PET. If it is a young patient, it's likely physiologic. If it's an older patient, it could be an incidental endometrial cancer. Here is another incidental finding. This patient had a FDG PET CT, and we see this uptake in the gallbladder. On this fused PET CT image, we find activity in the gallbladder. And so the gallbladder on the ultrasound is perfectly normal. And so this is physiologic excretion of FDG from the liver into the gallbladder, which can happen and be seen like this rarely. This is our next patient. On their rotating image, we find that there are several foci of increased uptake, and these are seen right here and also in the axilla, and there are these two axillary lymph nodes that are hypermetabolic. This patient had received a COVID vaccine a day prior to their PET CT, and we see hypermetabolism at the site of injection and also in the axillary lymph nodes. So remember this variant, if the patient have had a vaccine, you can see uptake at the site of injection and also in the regional lymph nodes. This next patient has history of breast cancer, and we see recurrence in the left axilla. They've had prior surgery, mastectomy. We see a breast implant on their CT, and in the region of the axilla, we found this large mass that was hypermetabolic, that was a recurrent breast cancer. But also on this next set of images in the same patient, as we were reviewing the abdomen and pelvis, we found free air. And this free air is also seen right here. And this was a complication of their diverticulitis, where we see some uptake of FDG as a result of inflammation, also seen here. And there is some fat stranding that suggests inflammation and a focus of free air in this region also. So this patient had a outpatient FDG PET CT for restaging of their breast cancer, and at that time they had a complication of diverticulitis seen as perforation on our images. So be aware that sometimes you can have urgent or emergent findings that can be seen, and they need to be picked up and conveyed to the referring physician. These are two separate patients. On the left, we have a rotating image where we see uptake in bilateral hilar lymph nodes, and this uptake is symmetric. This next patient shows uptake in the head and neck region, in the muscles of mastication. The first patient had sarcoidosis, and the second patient was chewing gum at the time or after their FDG injection during the uptake period. This is another patient showing brown fat uptake that we saw earlier. In this patient, we also see uptake in the wall of the right atrium. And this artifact can also be confused with malignancy, or this benign uptake should not be confused with malignancy. Here's our next patient. On the rotating image, we find that there is intense uptake in the skeletal muscles of the lower neck, upper chest, and also the intercostal muscles. And we see the uptake right here on the fused PET CT images. And this patient was short of breath, and they were recruiting accessory muscles of respiration as they were trying to breathe. And so shortness of breath or dyspnea can also lead to muscle uptake on FDG PET. These are two views from their CT of the chest showing extensive emphysema that was making them short of breath at rest when they were getting the PET scan. This next patient was being evaluated for lymphoma. There is some residual disease in the right paratracheal region that we see right here. And in their anterior abdominal wall, in the subcutaneous space, there are these multiple foci of fat stranding which show hypermetabolism, and these are from fat necrosis secondary to Lovenox injections. This next patient was diagnosed with a advanced breast cancer. Here's their primary in the left breast, and metastatic disease in the left axilla and also in the left internal mammary node. We see the findings here: left internal mammary node uptake, left axillary node uptake. They also had two other foci, one in the right side of the neck and one in the pelvis, and these two foci corresponded to a thyroid nodule and again endometrial uptake. Being a young patient, this endometrial uptake was reported as physiologic, and the nodule was biopsied. It turned out to be a benign adenoma. And so we frequently see focal hypermetabolism in the thyroid corresponding to a hypodense nodule. This should be biopsied, as 50% of the times this can be a second primary in the thyroid, a thyroid cancer. This next patient shows ill-defined mild uptake at the inferior border of the scapula. This is seen right here. And at this side, we have on this contrast-enhanced CT some enhancing abnormal soft tissue. This is a benign tumor called elastofibroma dorsi. Also, we notice in this patient that in the posterior aspect of the left lung, there is this diffuse mild uptake, which we see right here. This is from dependent atelectasis. So when there is atelectasis, we may find mild FDG uptake on a PET scan. Here's our next patient. They were evaluated for recurrent or residual lung cancer post chemoradiation, and we see this band-like intense FDG uptake that corresponds to these opacities with a linear border in the left lung. And this finding is characteristic of post-radiation pneumonitis and not residual disease or recurrent cancer. This has to be recognized on FDG PET CT studies and reported as such. What we can do is we can do follow-up imaging in the next few weeks and see if this gets better. Usually it does, because this is inflammation and it responds to conservative management. And so this is a follow-up on this patient. The opacities are much better, and the hypermetabolism that we saw earlier has almost completely resolved. So a great example of post-radiation pneumonitis on FDG PET and its resolution a month later. So typically when patients have received radiation, we want to wait for 12 weeks before doing a follow-up FDG PET CT, which translates to about 3 months. For chemotherapy, we want to wait for about 4 to 6 weeks. Here's our next patient with laryngeal cancer. We see intense hypermetabolism in the larynx, and there is no evidence of metastatic disease. They underwent chemoradiation and surgery. On their follow-up study, we find that there is a focus of mild uptake in the left submandibular gland, and this finding suggests radiation sialadenitis. This next patient was evaluated with FDG PET, and we see multiple confluent foci of intense FDG uptake in their abdomen, and these foci correspond to these omental densities. So this patient has carcinomatosis and omental caking, which is showing intense FDG activity. This next patient has intense uptake in the right hemithorax, and on the fused images we find that there is pleural thickening, which shows intense hypermetabolism. So this finding is consistent with mesothelioma. Here's our next patient. They were diagnosed with head and neck cancer, and we also saw a focus in the liver. They were treated for head and neck cancer. Post-treatment, there was resolution of the foci that was seen earlier in the head and neck region, but the focus in the liver persisted. And this focus was misregistered on the PET CT images seen here in the liver. On the contrast enhanced CT that they had as a follow-up, there is this enhancing mass in the gallbladder, which is also seen right here on the coronal image. And this gallbladder mass was the one that was hypermetabolic, but because of the misregistration, it was projecting over the liver. And patient underwent cholecystectomy. This was found to be an intracholecystic papillary neoplasm, a rare tumor that can happen in the gallbladder. These are multiple images from a patient's FDG PET CT study. This patient initially was diagnosed with a lymphoma. We see extensive disease in the abdomen and pelvis. And then post-therapy, they responded well, and there is a complete response. All the hypermetabolic foci have completely resolved. On their follow-up PET CT, there were these wedge-shaped, ill-defined areas of hypermetabolism in the liver, and on a contrast enhanced CT, these corresponded to enhancing parts of the liver, and the other parts of the liver were infiltrated with fat. So focal fat sparing was seen as hypermetabolic foci on this patient's PET CT scan. So another important artifact to be aware of. This next patient was being evaluated with FDG PET CT, and we see these multiple foci of increased uptake in both lungs in a symmetric fashion. And on their images of the chest, in lung windows, we find that there are opacities, there are consolidations in a symmetric pattern involving bilateral upper lobes. There's also hypermetabolism seen in a subcarinal lymph node. This patient had tuberculosis showing FDG uptake. Here's our next patient. They were being evaluated for recurrent melanoma, and on their whole body image, we find that there are these subcutaneous multiple foci of FDG activity in both lower extremities, and there are some that are seen on the trunk and also in the upper extremities. These foci are seen as fat stranding on the CT and seen as this ill-defined hyperechoic focus on the ultrasound. These were biopsied and we found fat necrosis. So it turns out this patient was on immunotherapy, which led to fat necrosis. Fat necrosis was hypermetabolic and seen like this on FDG PET CT imaging. This next patient with FDG PET CT showed linear intense uptake in paraspinal muscles, and this was secondary to muscle spasm from a compression fracture. Here's our next patient. Their FDG PET CT study showed multiple foci of increased uptake in the pelvis. The CT showed insufficiency fractures, and those fractures were also seen on the whole body bone scan. And here in the bottom right, we have some data from their DEXA scan showing that they are in the category of osteoporosis. This next patient had a large clot in their left ventricle. We see the clot here in the CT as a hypodense focus, and also we find that there is a photopenic defect on PET images related to that apical thrombus. All right, so this was a whirlwind tour of common artifacts and pitfalls on FDG PET CT imaging. Hope you enjoyed these cases. Check out my 2 books on the Apple bookstore. One is a handbook of nuclear medicine. The second one has all the cases and multiple choice questions. Also, I offer 2 on-demand courses on YouTube. One is a radioisotope safety course where I go over the physics of nuclear medicine, and then the second course is the 100 cases course, where each case is associated with 4 questions, and these are both on demand, available on YouTube. You can find more information on my website at nuclearmd.com. Thank you for watching.